Let the students in. Good morning, everyone. Welcome to Teleshadowing. Today's session will be led by two medical students. So first up, Minahil is a student at the University of Maryland School of Medicine who is a published author in healthcare disparities and is a patient advocate. And coming soon will be Nora, who is a student at the George Washington University School of Medicine who is also passionate about social determinants of health. Thank you. All right, good morning, everyone. So today we're going to be talking about social determinants of health, which is the third part in our patient care month series. So we'll start off with a video, just to kind of introduce ourselves to the topic.
Hey, Dad! I wonder if we'll see anyone we know at the carnival today.
Daddy, that's my friend AJ and his dad.
Hi, Samantha. Are you going to the carnival too?
Yep, I can't wait.
Me neither.
Hey, AJ, look! That school is a lot bigger and nicer than ours.
Yeah, they probably don't even have to share rulers and markers in class like we do. And their playground looks brand new. A lot of things in this neighborhood look different from our neighborhood.
That's true, AJ. Some neighborhoods look different than others and have different resources too.
What are resources?
Resources are things like hospitals, schools, stores, parks, and restaurants. There are different types of resources in every neighborhood. Some communities have less resources than others, or resources that aren't as nice.
The types of resources in the places where we are born, live, learn, work, play, and worship affect both our quality of life and our health. We call these social determinants of health, and they can be grouped into 5 major categories. Economic stability means people are able to afford things like healthy food, healthcare, and safe housing. Employment or job programs, career counseling, and availability of childcare can help increase economic stability in communities. People with higher levels of education are more likely to be healthier and live longer. But some children live in places with poorly performing schools, and many families can't afford to send their children to college. Programs to help children and adolescents do well in school and help families pay for college can also help people be healthier in the long term. All people should have access to quality healthcare. Increasing health insurance coverage helps make sure more people get the healthcare services they need, like preventive care, including screenings and ongoing treatment for illnesses. Everyone should be able to live in a safe neighborhood where it is easy for them to make healthy choices. Safe and healthy neighborhoods have access to parks and safe sidewalks for walking and recreation, access to stores where healthy food is always affordable and available, and safe and reliable transportation. People's relationships and connections with family, friends, coworkers, and community members can have a major impact on their health and well-being. Programs and policies to help people have the social and community support they need are important for supporting health and well-being.
Yay! We're here! I'm glad the carnival is a resource we can enjoy.
Social determinants of health are connected and related to each other. Together, all of these things will help improve the overall health of people. By working together, we can help ensure everyone has access to the necessary resources and support they need to be as healthy as possible. Learn more, take action, make a difference. Visit cdc.gov/health equity to learn more.
All right. I hope everyone was able to hear that. I know we had some technical difficulties with the video, but we'll make sure that everyone can access it after the session. So today we're going to be talking about, basically, we're going to give the basics of social determinants of health. I know that was the introductory video, but we'll get into more detail. We'll do a little bit of a workshop where we're going to be exploring the website, basically on the CDC and how to access different resources about it. It's a very complex topic for sure. Then we're going to be talking about the Institute of Medicine and its report. It was this report released in 2003 about social determinants of health and when it was first introduced. And then we're going to be talking about implicit bias and healthcare disparities, finally, the Healthy People 2030 initiative, and then finally some future considerations. So, social determinants of health. It's a very complex topic. I think that social determinants of health are just these external factors that have an impact on us rather than what's going on in our bodies physiologically or mentally. It's just the circumstances that impact us, like our social environment, our income levels, our house and neighborhood, our employment status, race, ethnicity, etc. So, everything from our physical, mental, and behavioral health, as well as just our social well-being, socioeconomic or SES status, race, gender, environment, even genetics, they all make up who we are and how we, as unique individual people, experience life. So these social determinants of health are just these critical factors that influence our overall health. Um, so, you can think about someone who is just not able, for a variety of reasons, is unable to keep just steady in employment. And so they may have a diagnosis of depression or any underlying medical conditions. And so the stress that's brought on by their employment can actually lead them to deteriorate further mentally. So maybe they begin sinking into a severe depressive state, and then in turn, they might struggle to seek or struggle to seek more gainful employment. This is very relevant to healthcare because we know that we're treating people, but remember that if someone's not able to access their medications, we can keep prescribing all we want to, but they're not going to be able to get better if they're not able to afford the healthcare that we're delivering to people and our future patients. And Noor, feel free to pitch in if in case I miss anything. You're more than welcome to, and I'm totally interruptible. If anyone wants to, ask any questions as we go along, feel free.
Yep, sounds good.
Awesome. All right. So basically, on this website, when you search up social determinants of health, this is the first thing that we see. We see economic stability. This is one of the 5 determinants of health. So, because of someone's unemployment status, their income isn't secure and they don't have health insurance. So remember last week we talked about employer subsidized insurance and how people rely on employment to access health insurance and healthcare because otherwise, private insurances tend to be much more costly. So, this person who is not employed can't afford to really pay out of pocket for physician visits and treatment for any medical conditions. If they're struggling to just put food on the table or struggling with their with house bills or having to feed a family, they're not going to prioritize their health care. So this leads to even more deteriorating health and poor self-care. And so the cycle just builds up and continues to grow and grow. So think about the impact on the community and how it's multiplied over and over again. And then there's also education access and quality. So not everyone has access to quality education for a variety of reasons. Sometimes no one else in their family has gone to college. There is K-12 education, but then there's issues with transportation. There's issues with broadband and internet access. So even if you are provided education let's say in public high school, I know I went to a high school in a rural area where I had friends and classmates who didn't have internet at home. So they had to stay at school to do their homework until, about 6, 7 p.m. Then they would go home. Whereas, I know I would be able to go home by, right, at dismissal, 2, 3 p.m. I'm home and then I can work on my homework. And I just had a better facility for myself. You can see in the video, there are people who have better schools. There are schools that are better funded than others. There are places that are that have many more resources than others. There are many systemic reasons for why, and education access and quality is one, is one detriment to some people, and it's not very equal across the US, which you would imagine, even from the K-12 system. And then of course that funnels into college education as well. Then there's healthcare access and quality. We talked about this. People who don't have health insurance may not be able to access high quality healthcare. Even people with health insurance, there are different types of health insurances. Some don't have dental coverage, some don't have vision coverage. So these are all things to think about when we are seeing patients for the first time. Do they have these resources in place to be able to access the prescriptions that you're prescribing them?
Yeah, and something to actually add to that last point is that access isn't just a financial perspective where there's through like the personal financial situation or their insurances. It's also just there's a shortage of doctors in specific areas, most often rural places. Urban places typically have it covered because there are like a lot of providers who are concentrated in those areas, but sometimes people in like rural areas or lower income areas have there's like no doctors don't tend to work there. One another reason of that is usually uh, it ties kind of back to like insurances, unfortunately, because low-income areas typically only have Medicaid, which doesn't pay private practices or hospitals very well. So there's no incentive for them to practice there. And so that's one other barrier to the health, to access to care and also quality.
No, for sure. You're definitely right. There are places called health professional shortage areas, HPSAs. There are also places called medically underserved areas, MUAs. So there are all these factors where, you would imagine, okay, why don't we just throw resources there? Let's have doctors there. Doctors don't want to work in these rural places because they're not financially incentivized to do so. So
Just to
this is
give,
where,
sorry, go ahead.
no, go ahead.
And just to give an added layer to that is if you overlap a map that shows the shortage areas and comorbidity rates are so much higher in areas that have a lack of primary care providers. And life expectancy
Right.
tends to be lower on average.
Yeah, I'm actually going to pull up a map that we can show people in the, so let me see. Um, I'm opening up MUAs. Let's see. Yeah, so here, can you guys see this map that I'm playing? Yes, no. Okay. Well, if I just look up, health, shortage areas, you can see here basically in yellow, yellow is where doctors are needed, basically. These are medically underserved areas. And you can see a correlation, like New York City is here, this is Washington, D.C., San Francisco, the more highly populated areas like Houston in Texas.
Major cities are well covered.
Exactly. Here's Chicago, and gray means well covered, and then yellow means medically underserved. So there's definitely a gap and a barrier there for sure. All right. And then our neighborhoods. You might not think that our neighborhoods or our built environments necessarily affect our healthcare and health and safety, but really they do, because sometimes you might live in a neighborhood that isn't necessarily safe. That impacts your ability to go outside and exercise, right? And if you want to go out for a walk, if you want to go for a run, if you don't feel safe in your own neighborhood, that's true. I know I go to school in Baltimore, and I know that there are many patients who are just not able to exercise, number one, because gyms are very expensive. Number two, because I remember a patient once told me, if I go outside, I'll get shot. And this is very true. There are places in Baltimore, specifically West Baltimore, that are just not necessarily safe for families and people. And then you might ask the question, well, why don't they just move out? That's not a very easy, and not a very easy thing to do, especially if you have your roots planted there, you have your community there. And also some people just can't afford to move out either. The
Yeah.
cost of living is very expensive in the suburbs.
Another thing on that is, unfortunately, a lot of places that are more affordable tend to be located near plants or areas that have high rates of pollution, and that further impacts individuals' health. I think half of DC is like downstream of like the major source of pollution. I think it's like the main station, and as the rates are like super high there.
Exactly. So, Noura, she goes to school in DC. So that this is a very good perspective to have here as well. I didn't know that before. So thank you for sharing. All right, and then the next social determinant of health is like social and community context. So basically, the United States is infamous for having this, I guess you could say this marginalization of minorities. We know that there is a racist background in the U.S. There is these racial contexts that we have. So basically, what people have been trying to do nowadays, it's how can we solve racism? But unfortunately, even after the 1963 Civil Rights Act, there have still been traces of it and generational trauma that affects communities, specifically marginalized communities. And this ultimately impacts well-being, mental health, and ultimately our healthcare.
Yeah. Unfortunately, there's a lot of institutional racism or class oppression, gender discrimination and exploitation, accessibility, or the lack of accessibility for people. And a lot of the time, sometimes there's communities that'll support each other, which is really good and helpful. It's so important to have those family and friend connections to like help support you or maybe make connections through that as well.
Exactly. And it's just a matter of like historically people might ask like why is there a correlation between minorities and a lack of healthcare? It's really because of over the generations there has been generational wealth accumulated in marginalized populations because they just weren't allowed housing, until about 60, 70 years ago, right? And there's still some access barriers for sure.
And unfortunately, like everyone has biases. It's hard to like you don't even have them. Implicit biases are unintentional. And I don't know if you guys heard of this paper that came out not too long ago because it was like, advent of AI and such. But they tried to use it in the medical context, and unfortunately, it followed the bad patterns of the historical like way providers used to prescribe medications, and left a minority community out of care.
It is very unfortunate. And we're going to actually be talking about these implicit biases, and we're going to be talking more about that, and we'll learn more about it because I think it's important to have that education and awareness. So we're going to just give a bit of a relative historical context, continuing on from last week. We sort of ended in the 1990s to present, but I'm also going to talk a little bit more about what was at the actual state of healthcare delivery in the 1990s. Actually, as we know, there were rising healthcare costs as more and more, medications and science advanced. It led to rising healthcare costs in the US. This actually led to patient safety concerns. There was actually an increasing number of uninsured Americans. Remember, that's why the Affordable Care Act was passed in 2007. That actually led to an increase in medical errors because there were rising healthcare costs and patient safety concerns because of increased medical errors. And we wanted to know why. In fact, there were also some preliminary reports on racial and ethnic minorities that were receiving lower quality healthcare than whites. So this actually led into Congress to mandate in 1999. They commissioned the IOM, or Institute of Medicine, to determine the extent of racial and ethnic disparities in healthcare and to actually understand, is this actually true? If so, what are the sources and why is this happening? So I'm just going to give you a little bit of background on the IOM, or Institute of Medicine. Basically, they were established in 1970. It's the health arm of the National Academy of Sciences, and the National Academy of Sciences was chartered under President Abraham Lincoln in 1863. So basically, they added, so here's sciences, and there's engineering, and then medicine. So they actually added these two institutes later on so that they wouldn't work in silos anymore. So basically, the sciences, engineering, and medicine all make up the National Academy of Medicine, which advises the nation on medical and health issues. It's actually an independent and nonprofit organization, so it's NGO that works outside the government to provide unbiased and authoritative advice to decision makers and the public. You can sort of think of it, it's like analogous to the WHO, the World Health Organization for, the globe, but this is more so like the WHO, how I remember it, the WHO for the US. So basically, once the Academy of Medicine was commissioned to do some research, they did this in the late 90s, and then they spent a couple of years on it, and they released this report in 2003. Basically, the report was entitled "Unequal Treatment: Confronting Racial and Ethnic Disparities in Healthcare." So that's when they actually. So not only did they investigate it, but they actually found it to be true that there were racial ethnic disparities that were happening. But ultimately, they concluded that although that there are a lot of sources that contribute to these disparities, like we mentioned, the social determinants of health, there's actually some evidence that suggests that there's bias, prejudice, and stereotyping on the part of healthcare providers. And this actually might contribute to differences in healthcare that's provided to us. Now, I want to ask both me and Nura, like, why is this relevant for us to know? It is a rhetorical question, but just preliminary thoughts, like why should we know this and why is it relevant to us?
I can give a stab at it real quick. So, the more you are aware of your biases and existing biases or prejudice and stereotypes, the more you can address them or not fall victim to them. So, a common example is that you have a person of color or a white patient come in, both of them are complaining of like incredible pain. And then the option to prescribe them is like Tylenol and ibuprofen or a low strength opioid. More often than not, is the white patient will be prescribed the opiate and the person of color will not get prescribed the opiate, and so their pain is not addressed. There's surveys have been conducted to see like why this is happening. A lot of people report that it's because they feel that the patient's pain is not as high as it's being like they're over reporting their level of pain. Because and another aspect of that is that people generally believe, which goes back to like like really wrong ways of thinking,
Mhm.
where because genetically, and this is completely untrue, it's been proven to be not found, like it's completely unfounded, that genetically they are more like tough, resilient to pain than their white counterparts. And unfortunately, like if you're aware of that, you can avoid that. There's actually people that are working on addressing this right now. They have, I think, I don't know if it's UW hospital that does this, but they have a I forgot what it's titled, but a little notification will pop up saying like, "Hey, this patient could benefit from reviewing their medical history and asking them these questions just to give them better care and like to avoid, like to remind them, hey, avoid biases, take care of this
Mhm.
patient on where the patient needs care."
Now, these are great interventions that have been introduced in many electronic medical records as well. The most used one in major hospital systems is called Epic. So that is definitely something but unfortunately, you're thinking it's 2024 right now, and this report was released in 2003. So I'll talk to you about why all of a sudden this has become a buzzword and why it's become more highlighted in recent years, especially. So I would say it's also relevant because we're sworn to do no harm, right? It's non-maleficence. We talked about this in our first video of the series where we talked about these are the principles, these founding principles as physicians. We must consider the possible harm that any intervention might do, right? So it goes against what we've actually been sworn for, where it's remember justice. There was this equity and justice that we talked about. We want to be patient advocates, but why is this happening? Why are we also part of the source of the problem? And remember that like physicians have this special ethical duty to act in the patient's best interest. So remember, we are sworn to these ethical and healthcare ethics that we're reviewing now. But if you want to learn more in more detail, it was in our first part. So, remember, if we're not fulfilling the rights each patient has upon us as the future healthcare providers, then what'll happen? Well, actually, it leads to mistrust in healthcare system as a whole. So patients will not trust us as medical providers. Ultimately, the IUM, the Unequal Treatment Report, it addressed this question of how could bias, prejudice, and stereotyping contribute to unequal treatment, especially given that healthcare providers were sworn to beneficence, and we can't, by law, discriminate any patient on the basis of race, ethnicity, color, or national origin. But as Nora mentioned, these are sometimes unconscious biases. Remember, we are all coming from different backgrounds and schools of thought. So it is interesting to think about because here, this is actually a recent study where healthy professionals, and we know this, and systemically, they've mistreated the Black community. Unfortunately, this is pre-1900s. People would be testing on people of color for different treatments and prescriptions. And this was before the FDA was involved and before patient safety regulations were introduced. But there's a reason why these policies were introduced because there were some serious ethical imbalances happening in the medical community until this was addressed. So remember, racism was not just civil rights issues. Racism was also issues in medical healthcare spaces. And as we know, many doctors back in the day, we would only learn diseases on white skin tones. We would not know what a rash would look like on a person of color skin tone. But now things have definitely changed. I know that I've been learning nowadays. I see rashes on different skin tones because we need to be equipped to be able to see it across all races and ethnicities and colors. So that's just one thing. Another thing is just the widespread healthcare disparities in minority kids, how they start at birth, because we know that um, there's a greater fetus mortality rate in Black populations, and that's awful. Why is that? Why is it just by race? Even after there are studies that controlled for every other status, for socioeconomic status, there all the other social determinants of health. Why is it that it just comes down to race? That differentiates and just puts you at risk just for being Black or a person of color for your newborn to be at a greater risk, a greater health risk. So that's something interesting to think about, and we'll address that and explore some things. So basically, this is from the 2003 report, where it actually talked about this substantial difference between minority and non-minority populations. Um, and where the difference and disparity actually came from the operation of healthcare systems and discrimination, where it came down to biases, stereotyping, and uncertainty. And this is not, I'm not talking about the 1960s, 1950s, 1940s. I'm talking about 2001 and, the 21st century. It's still an issue today. So it's important to acknowledge. So you might be wondering, what is the evidence for the racial and ethnic disparities in healthcare? Is there actual evidence that healthcare providers are actually biased? In fact, there have been studies that have shown that there is a higher mortality among minorities, even after controlling for different social determinants of health. Of course, they still play a role, the different social determinants of health, they still play a role in the ultimate outcomes of the patients. But ultimately, this is why sometimes providers need to be more proactive and vigilant about people from different races. So, let me move on to the next slide. Yeah. So the different sources, right? There are different sources for disparities from healthcare. There's health systems level factors, which include financing, structure of care, cultural and linguistic barriers. There's also patient level factors, which include patient preferences. Maybe they might want to refuse treatment, which is totally up to them. Sometimes patients have poor adherence. Sometimes they're not able to adhere to medication regimens. Like I said before, sometimes they can't afford it. It's not necessarily they're non-compliant. So this is a new terminology that we've introduced, that they're non-adhering, not non-compliant. And then sometimes there are disparities arising from the clinical encounter itself that we'll explore more. So in detail, let's talk about, the source, the healthcare systems level factors. So there's cultural and linguistic barriers sometimes. Sometimes we do have medical interpreters available, but that might lead to the patient wanting to say a little less or not completely talk, say everything that they're experiencing. Remember, we talked about history taking last week, and we said that almost 75% of a person's differential diagnosis or actual diagnosis can be figured out from the patient's history. So many non-English speaking patients report having difficulty accessing appropriate translation services as well. Not every hospital system has the resources to have medical interpreters. So to patients, we might just sound like this. What are some potential ways to fix this? Well, there's some programs where we can learn medical Spanish. There are also ways that, try to involve the rest of the family of the patient. I know in rural areas, there are ways to have tele interpreter services where you on the phone, you can go back and forth, but there's still that barrier. Patients, I know that if I'm a patient, I want to be able to speak the same language as my physician because they're taking care of my very intimate and private healthcare. And then there's also this lack of stable relationships with primary care providers. As Nora mentioned, we do have a shortage of PCPs or primary care providers in rural and medically underserved areas, where minority patients, even when they're insured at the same level as whites, they're actually more likely to receive care in emergency rooms and have less access to private physicians. So that's something interesting to think about.
And another to add to that actually is, how do I explain this? So when there's a language barrier, it's not just that the patient isn't going to feel like a huge part of all this ties back to trust between the patient and the provider, that patient provider relationship. If they're not able to communicate, there's like a lack of a reduction in quality of care. The patient feels slightly uncomfortable sometimes. Even the provider and staff will feel uncomfortable and not know how to address the patient. And sometimes there's as Manal mentioned, there's difficulty in accessing those modes of communication. And another one for on hand is a company called Global, where you can just call and say what language you need and they can translate back and forth. But what about documents? Who's going to read the documents to the patient, translate the documents to the patient? Are there translated versions of that document that you can give the patient? But even with that, there's also this issue of delayed care, because it could take time to do all these things, get an interpreter, make sure that the meaning of what you're trying to direct the patient to do or have them explain to you, that could take longer. And unfortunately, in places like the emergency room that they often end up, it's so fast paced and there's so many urgent cases that are also happening at the same time that they can get forgotten or left behind or waiting for hours before they can receive care. And that's not really great because that obviously leads to poor care. Maybe they're having an emergency. There was a case of a child that the providers couldn't understand the mother, and they were thinking that she was saying he had asthma, and they're like, oh, he'll be fine, just put him on bronchodilators, when it was actually much more serious than that, and he became critical. And had they had the interpreter earlier, they could have avoided all of that, and then the bill for the mother was even higher than it should have been.
That's exactly right. I feel like these are all these are all little things that add up in a person's life. So imagine you're going through this your entire life. You have delayed care. You don't understand your discharge instruction. I'm doing some research on that actually when you brought that up. That reminded me. Like there's disparities in the readability of discharge instructions, even in English. So it's a matter of health literacy and being able to be understood by the patient, even if there isn't a linguistic barrier. We shouldn't be using medical jargon either. So
Yeah, exactly.
exactly. So that's what that these are all things to keep in mind for future patients. We need to be more vigilant for them and understand that equity is not necessarily giving everyone the same thing. Equity is actually sometimes giving someone a little extra thing compared to the other person because they've had these different life experiences and how it shaped them as a whole, and it might affect
And
adversely.
one last thing, I know we need to move on, is it's like this kind of ties back to what you were saying, health literacy, because studies have shown that patients with low health literacy, whether that's through communication or whatever reason, they're far less likely to follow those treatment plans that you want them to follow. They have higher mortality rates as a result. They have more hospital stays and more trips to the emergency room.
I couldn't have said it better myself. Thank you, Nur, for bringing up that study. So you can see here we have all this data, but now it's a matter of what are the policy actions that have been put in place? What are some changes that have been happening and have there been happening, even though we see that there's been a lot of these different data and studies coming out. So the next type of factor for source of these disparities is patient level. For example, just like, if there's a poor cultural match between patients and providers, that might lead to a misunderstanding of provider instructions. And so also having a poor prior interaction with the healthcare system might lead you to mistrust it and a lack of knowledge on how to best use services. So remember, this comes back down to health literacy and understanding that we need to be able to understand differences in patient attitudes, such as preference or treatment. I know many Muslim patients, they prefer to be treated in a different, might want to have more cultural understanding of their backgrounds. And then it's not just race, it's also ethnicity, religion, gender. Sometimes a preference in different populations that maybe I want a female physician, maybe I want a male physician for different reasons. So everyone, has a choice, and this is a privileged thing to say that I have a choice for my provider. If I'm in a rural town of a population of 500 people, there's likely going to be one doctor that's 20 miles away. That's inaccessible to me if I don't have public transportation services. So
Assuming
my
they even take your insurance.
Oh, and I might not even have insurance, right? If they might not even take it, or I might not have insurance, since ultimately I don't have healthcare. And the WHO has said that healthcare is a fundamental human right, and regardless of your social determinants of health. Um, so unfortunately, like while there are racial differences in patient attitudes, such as preference for treatment, they don't vary greatly, and they cannot fully explain racial and ethnic disparities in healthcare. Which brings us to this point, which is this is, I would say, the most critical finding from this report that we can because this is something that we can actually change and work on and addressing from an individual level. The disparities arising from the clinical encounter. So this is actually a picture from a New York Times article called Medical Gaslighting, where basically, you can see this physician and this patient where, the doctor's checking their heart, but here you can see the physician sort of towering over the patient, even though they're both on the same beds. Unfortunately, this patient is just being medically gaslit because they're like, oh, well, the issue is in your head, or there's nothing wrong with your heart, please go home. So, and these are things, and it might sound egregious today, but it actually used to happen relatively recently. So, There are some possibilities that were examined in 2003 for why there are these disparities coming just from the clinical encounter itself between the doctor and patient. This, let's go of all other society problems, issues, systems. So bias. There's no evidence that suggests providers are more likely than the general public to express biases. It's not a matter, it's just that we all have biases. Some evidence suggests that unconscious biases exist the same way health providers do as the general population. And then there's uncertainty. This is like a plausible hypothesis, particularly when providers treat patients that are not similar to them in cultural or linguistic background. So if I'm uncertain, like Noura said, I just assume the child had asthma, I'll just treat them with a bronchodilator. But I'm not really asking more questions. And then finally, there's stereotyping. There is evidence that suggests that providers, like everyone else, we use cognitive shortcuts. We stereotype, and we all do. We use the cognitive shortcuts, just like the example Nora mentioned again, the example of a patient of color and a white patient, kind of comparing their pain, giving the white patient a low dose opioid, whereas assuming that because of biological differences, which are not true, that people of color are better able to handle pain. And so they don't need the opioid. They're just these are cognitive shortcuts that people have taken, and sometimes these are embedded through us generationally because of the generational, I guess you could say, legacy that the US has had throughout history.
And just to put this into another context, as providers, they're constantly like triaging and prioritizing patients that they have to care for. So, like, say you have like three patients that are in the ER and only one ICU bed. Who do you prioritize? Who gets assigned the most experienced nurses? Who gets more attention? Are they non-adherent patient, or are they a familiar patient that you already know? Like, who gets more of your attention? Which patient will get extra attention to their care? And like these implicit biases, deep subconscious beliefs that you don't even know you might have, like about who matters, who's more valuable, those kind of um, beliefs and actions kind of creep into your practice or someone's practice. And it can occur in these tiny little decisions, like these quick snap minute decisions when you're trying to like prioritize people. There's this whole thing about triaging that I won't get into, but and it's not most of the time, if not like 99% of the time, it's not overt or intentional to like discriminate against somebody. It's just their attempt to prioritize as efficiently as possible.
Exactly. It's not done, and it's not necessarily done on purpose. And like we said, by law, we're not able to do that, but it could be done unconsciously. So there is, there's evidence, like there's a lot of evidence, actually, a lot of studies. There's one study published in 2000 by Van Ryn and Burke, where it was conducted in an actual clinical setting that found that doctors are more likely to ascribe negative racial stereotypes to minority patients, even when differences in education, income, and personality characteristics were considered. And then in 1990, more than 30 years ago, physicians were more likely to make negative comments when discussing minority patient cases. That was another study that found that. In 2000, there was found that medical students were more likely to evaluate a white male patient with symptoms of cardiac disease as having definite or probable angina, relative to a Black female patient with objectively similar symptoms. So I think that the IOM found the most evidence in cardiac cases. I think that was the easiest one back at that time. Because you can see, because there are different resources that are used to manage different cardiac cases. And then in 1999, a study by Ebru, they found that mental health professionals had trainees that were more likely to evaluate a hypothetical patient more negatively after being primed with words associated with African American stereotypes. So, there's this implicit bias test by Harvard. It's free. You can feel free to use it, where you can actually see different types of implicit biases, even if it may not be by color or race or gender. It might be by religion. It might be sexual orientation, right? So these are all different biases that we may have. And so if you take the implicit bias test from Harvard, you can actually understand and be more self-aware about your own implicit biases. I know when I took it, I was pretty surprised as well. Even though I am, as you can see, a person of color and a minority and a woman, I still have my own implicit biases. So I'm going to talk. So basically, ever since 2003, like what has the National Academy of Medicine done? If we're still talking about it, that means that it has not been solved. So they actually published a study in 2017 where they actually talked about some perspectives on health equity and social determinants of health. They actually also released different workshop recommendations. Now, in Maryland, there was a policy that was passed that mandates that Maryland physicians have to take an implicit bias training workshop. And what that means is that in order to get their license renewed. So, there's something called CMEs, or continuing medical education credits, that you need to have. And so they actually embedded it in that CME curriculum, where now Maryland physicians have to have implicit bias training workshops, and mandated by the state to be able to practice medicine, which is really good. I would say these workshops are a good step, a positive step in the right direction. And then, this is important to know as future healthcare providers and patient advocates, we need to call for collective action across all sectors to reverse the often like debilitating and sometimes lethal consequences of health inequity. So this now I'm going to be switching gears a bit into COVID-19. I feel like there's relevance of COVID-19 across many different cases. But I'm breaking this up here because there's no doubt that the COVID-19 public health emergency further increased the importance and necessity of addressing social determinants of health, such
Really
as
highlighted them.
right. It highlighted them. Unfortunately, it sucks that during times of a crisis, healthcare disparities are even more visible. And this actually answers the question I asked earlier, why are we talking about it more and more now? Because ever since 2020, we have been seeing this even more. So you can see here the COVID-19 hospitalization and death rates among active EPIC patients by race, and EPIC is the electronic medical record of major hospital systems. So you can see here, white hospitalization rate 7.4% and 2.3 not percent, in the millions. So white patients just had 2.3 million, whereas Black patients, more death rate across Hispanic populations and slightly in Asian as well. But you can see here the hospitalization rate was much, much higher. There's a clear disparity between minority groups and whites in terms of hospitalization rate and death rate. Even though the disease was the same, and the disease affected over 100 million Americans, over 1/3 of the American population. So that's a huge sample size. And this is as of July 2020, and it's shown worse since 2023 as well. So it was statistically significant that there was a difference. And so you might ask yourself, why is this happening? Unfortunately, it's a variety of reasons. It's not just one reason. You can't just define it as one, because social determinants of health are very complex. So, you might be thinking, how can we be a change, right? How can we change this? And how can this be the last crisis that makes us think about it? Because you think, maybe the HIV epidemic might have might have caused us to think differently. The flu, there were different flu pandemics happening even in between 2000 and 2020. So why did we not have such increased rates of conversations? But fortunately, we are having them now, where there has been a greater push for social justice and advocacy across all sectors, and healthcare is not and is definitely one of them. So, from the federal level, you think there's different levels of policy that can be made. There's the federal, which is the state, national level, then there's state, then there's county, district. Even in different jurisdictions, they have their own different policies. So at the national level, there's this initiative introduced called Healthy People 2030 by the Department of Health and Human Services, which is basically every state has a Department of Health. So this is the United States Department of Health. You can think about it like that. And so they have these 5 key areas where they talk a little bit about this framework where they talk about health disparities. Basically, they keep these 5 things in mind. They want to address each of these 5 things, these key factors. And if you explore it on their website, it'll tell you exactly where they are in the process of achieving this goal by 2030, or reducing the impact of healthcare disparities. So we've just found basically the main definition of healthcare disparities is something that affects you, a health difference that affects you as a result of your social determinants of health. And so Healthy 2030 Healthy People 2030, it has these data tools that wants us to assess it because we do need more data to really tell us how we can do better. Data informed decisions are the best way we can make policy changes because without evaluating our community needs and without actually understanding what needs to be done, we can't just throw policy solutions out there and not have them work. Then we have health equity. Health equity we've talked about. It's defined as the attainment of the highest level of health and well-being of all people. And it requires people valuing everyone equally. Whether there be people of different races, ethnicities, abilities, people who have different abilities or disabilities. And so achieving this health equity, it requires us to be focused on different societal efforts to address these inequalities, as well as the historical and contemporary injustices that we talked about, the historical racist legacy that the United States has had over 200, 300 years is not going to be reversed in just a matter of 50 years. There needs to be more work to be done, and it can be done much faster. So achieving the equity, it goes hand in hand with healthcare disparities. We need to reduce and not just reduce, but also eliminate health disparities. And it starts with us, and it starts with us and also health literacy. We play a role in the health literacy of patients. So basically, this initiative divided up health literacy into two aspects. There's personal health literacy, which is the individual's ability to use health information to make well-informed decisions. And then there's also organizational health literacy, which is the organization's responsibility to create health information or discharge summary, discharge records that is accessible or readable to patients at a fifth grade or sixth grade reading level. I know that it's easier to read and absorb things, even for me as a medical student, if it's at an easy to read level, so that I can actually act upon it and make sure that I'm staying adherent. And then there's well-being, where well-being is just this, they're working on overall life satisfaction. So mental health was also a big thing that arose from the 2020 pandemic. Then there's also an ability, also as we are aging, we know that our population is aging a lot. So like you can see, the Healthy People 2030 is trying to be all encompassing. Now we'll see how effective it is and how successful it becomes as a national initiative. But we're all part of this initiative because we should all be working towards it. And then finally, the fifth key that they're working on is the social determinants of health. So we talked in detail about social determinants of health, but now we're sort of macro analyzing, seeing how we can step back and incorporate the SDOH into these other aspects like well-being and health equity. So we've talked about this, how these are different environments and different factors that like affect our health and well-being. And so if you want to learn more about the Healthy People 2030 framework, you can visit healthypeople.gov and just you can see the status of where we are in all five of these areas. And then the social determinants of health has its own subcategories that we've also talked about as prescribed by the CDC and different federal partners. So this is just like one type of initiative or policy platform, you can say, of people actually wanting to go towards the right direction. And this is actually a very recent video. It was released last year, so it's a very interesting framework. And now we're going to sort of leave you with food for thought and future considerations and recommendations. So I'm going to stay on this slide for a bit. We're going to have a bit of a discussion because the general recommendation is that we need to increase awareness of racial and ethnic disparities in healthcare among the general public and key stakeholders, not just healthcare providers, but also policymakers, and increase our awareness of disparities as a whole, as a collective whole, as a public. Like I said, we have biases that we have just like as the general public does. So we need to try to be more aware of them. Take the Harvard implicit bias test. It doesn't take that long, and you'll learn more about yourself and how we can better. It's hard to say how can I fix something that's unconscious, but being more aware of it is the first step. So it can actually increase healthcare providers' awareness of disparity by increasing all awareness overall. Awareness is definitely the first step. Then there's also like interventions and like legal, regulatory, and policy recommendations that we can make. We need to sort of avoid fragmentation of healthcare plans. And what I mean by fragmentation is that unfortunately sometimes healthcare provider teams they're not all in one place because not all that's a hospital, right? But when you're thinking about healthcare, the most immediate healthcare that we have access to is our primary care provider. And so there are places in the country, in the majority of the country, that are medically underserved besides the major metropolitan areas and cities that need healthcare providers. And so we need to increase financial incentives for doctors to work in these areas. There's also been a push for They're considered mid-level providers, such as nurse practitioners, physician associates, or assistants, to be able to increase the proportion of all of healthcare providers as a whole, not just doctors. But also, we need more physicians of color. We need more people in healthcare who are underrepresented in medicine. Because if you match there's actually a huge disparity. There's like a population of about, I think, 11, 12% of African Americans, but only 2 or 3% African Americans are doctors, if that makes sense. So the doctor as a whole population, and I can also pull up that statistic where there's at least an 8% discrepancy. Whereas, for example, Asians, there are much more Asians who are physicians versus the Asians in a population as a whole. And then for whites, it's approximately the same because basically you want your health and provider workforce to represent the population it serves. So you don't want to have different underrepresented communities stay underrepresented because there are not as many Black female doctors being able to fully better able to care for Black people or for females.
Yeah, and
Um,
part of the idea for moving towards that is that when it kind of ties back to trust. When the patient feels like the provider is similar to them, they're more likely to trust them and be open with them, and then as a result, receive better care. And likewise, in the opposite way, the more the providers represent the patients that they're caring for, the better they are to understand that population and address the needs of for their care as a whole
exactly.
community, not just on an individual basis.
Precisely. That's why more medical schools are more incentivized to accept more people of color. That's much more needed more than ever. I know that my class is 70% people of color, which is great. And it's a great first step. And so we'll see after during this Gen Z, this I guess older Gen Z population of people becoming physicians and see how that might impact our future healthcare industry. So now as for education and health literacy, so we need more patient education programs that should be implemented to increase patient knowledge of how to best access care and to participate in treatment decisions. So that includes having caseworkers on your team, having social workers more than ever, having access to social workers, right? They exist, but being able to connect the patient to the social worker, there are barriers that exist between these different healthcare, I guess you could say, key stakeholders for the patient. Um, and then we should also try integrating cross-cultural education into training of all future healthcare professionals. I know that in my school, we do have like these mandatory electives and classes that we take to be more culturally aware and sensitive for different types of patient populations, but more can definitely be done, especially in the Latinx population and Hispanic populations. Um, and then we also need more data. There's still many areas of future research because we need to be able to collect data and also monitor it so that we can see if we're actually reducing or eliminating healthcare disparities. And then we can monitor progress towards elimination of these disparities. And then, as for areas of future research specifically, we can conduct further research to identify sources of racial and ethnic disparities, and assess promising like intervention strategies. I know that I was part of a study that helped provide free transportation for COVID-19 treatments, the monoclonal antibody treatment, because many people didn't have access to transportation when they had COVID-19 back then. And so we're trying to assess was that intervention helpful? Is that something that should continue to be funded for different types of treatments? Because the next pandemic is not a matter of if, but a matter of when. So we need to be better prepared and think ahead and not have these healthcare disparities happen again and not have a higher mortality rate in marginalized communities. And then finally, we should try conducting research on ethical issues and other barriers to eliminating disparities because it's been 20 years. We've been aware about this issue, but we only really care about it when a crisis happens, like COVID-19, because that's when it's really, really highlighted. But these issues still exist even when there isn't a crisis. So that's something to really think about and food for thought as well. So, Noor, you were mentioning like how to make better clinical decisions as providers. Like these are just some things that we can consider. Like, did I consider causes besides the obvious ones, right? Because maybe the obvious ones to me might be different from obvious ones to Noura because we have different biases. How did I reach this diagnosis? Did I just make a cognitive shortcut and be like, okay, this person's Black, they're complaining about pain. I'm not going to give them an opioid because you know what? I think that they're able to better handle it. No, that's wrong. That is completely wrong. Did I ask questions that would disprove rather than confirm my current hypothesis? Now this is a matter of history taking, right? Not coming in with biases when you're coming down to your history taking, because like I said before, 75% of diagnoses can be done with an effective history taking strategy. Um, and also check, are you interrupting the patient, right? While they're talking, right? That sometimes happens. I know as a female in STEM, we do get interrupted sometimes by our male counterparts. It's just a matter, it's still an issue, with our different identities that we have. And then you want to ask yourself, and be honest, because you're just asking yourself, am I stereotyping the patient or this presentation? Sometimes we do. Sometimes we don't have all the information. Sometimes I have not seen this rash before in a population of people of color. So these are some things that I should do more research on, and that's okay because this profession is full of lifelong learning. So, that you're wrong more than often than you think. So this is a good humbling statement to remember that sometimes we are wrong, and that's okay, and that's a place of learning. And remember that just making sure that we have checklists like these in mind. This is not like an exhaustive list, but this is one way, a step forward, or a step two after knowing your implicit biases. That after that, then you can make a checklist for things that you should be careful of and wary of based on your specific implicit biases. So this was a healthcare equity video, but we've talked a lot about the different topics. So we can sort of summarize it here, where we're all reaching for healthcare equity. Like I mentioned, some people might need more or a little extra stepping stool to be able to reach the apple or ultimate best healthcare for our patients. And we want to try reducing these health disparities. It sounds like a very broad and umbrella statement, but it is possible through different programs, interventions that we can do and fund. And I'm going to leave everyone with this quote by Maya Angelou. If it is true that a chain is only as strong as its weakest link, isn't it also true that a society is only as healthy as its sickest citizen and only as wealthy as its most deprived? So it's a very good sentiment to think about because we're only as strong as our most medically underserved area because our healthcare systems might be at risk of collapsing during the next pandemic. And we don't know when that is a matter of when, not if. So we should be able to better equip ourselves in advance and be proactive. All right. Well, that leads us to our teleshadowing session quiz. The link to the quiz for today's session is now live. It'll be teleshadowing.com/certification. And next week, we'll be talking a little bit about research in medicine and how to actually get published and do some type of research. Either it could be in social determinants of health or in other topics in different areas. So we'll learn a little bit more about what are poster presentations, abstracts, what are all these different things that we need to do in academia, because it seems, and we've learned in medical school that really publications is like the currency in academic medicine and matching for residency. So we'll talk a little bit more about how you can get involved even as an undergraduate student or a high school student and sort of introducing you to research in medicine because we keep making new advancements and new things. So it's exciting to do, it's exciting to think about, and I'm looking forward to seeing you all next week. Take care.